Hi, this is Patrick Horn, president of GAP. Thank you to our sponsor, AbbVie, for their support of this podcast.
Hi, everybody. I'm Kim Orleck. I'm a physician assistant practicing at Atlanta Gastroenterology out of Atlanta, Georgia. I am thrilled to be here today with friend and colleague, Kristina.
Hi, everybody. This is Kristina Skarbinski. I'm a nurse practitioner. I've been working in GI for over a decade, and I live in Boston, Massachusetts. Happy to be here.
Thanks, Kristina. So I know you have years of experience, so excited to kind of chat with you today. We are going to talk today about setting expectations when initiating new therapy for our patients with IBS-C. And for those of you who didn't listen to our prior podcast, I know we really tackled how do we give that patient that diagnosis with confidence, really leaning and honing in on that positive diagnostic strategy. So obviously, Kristina, we really talked about getting that patient a diagnosis with confidence, really helping them to understand their diagnosis, all of that. And then it comes time to, we not only want to give them a diagnosis, but we want to get them better. We want to get them a therapy. Talk to me about shared decision-making. Like, how do you start to have that conversation with these patients about, hey, you've tried, a lot of these OTCs, you're here, you still have symptoms. Let's start to talk about what we're going to do next. Like, share some of your wisdom in that.
Yeah. So when a patient comes in to see me, obviously they're distressed. They've been through a lot. Like you said, they've tried all the OTCs. Nothing's really working. They're still trying to figure out everything. But when you're talking to them and you're getting a history, you want to hone in on what are their care goals, right? So do they want to tackle pain? Do they want to tackle their stool consistency, the urgency, any of those symptoms? So once you get a gauge on that, then you can move forward with the treatment plan that best suits what they want to tackle. So I usually tell patients IBS is a disease. It's a disorder. It's very real. A lot of times patients come in and they're like, this isn't real. Like, oh, someone told me it's all in my head. But it's really important that you change that frame of thinking, because we all know as clinicians that this is a very real problem for people. So once I start getting into that, then I'll move forward into, okay, there's many options. It's really important that you pick one, and then we can move forward and figure out response based on what you tell me. And then we can work together to kind of tweak anything that we need to.
I love that first part, Kristina, because I think we talked about giving them that diagnosis with confidence. And I think we see so often, right, these second and third opinions where they're like, but they told me it's in my head, there's nothing wrong. They don't really understand that pathophysiology, the why they hurt, that visceral hypersensitivity, right? So I think that's so important that we acknowledge with these patients with shared decision-making, like, we understand your symptoms. We know that they're real, right? And then taking it to the next step of, we also know you're frustrated because you've tried a lot of OTCs, you haven't gotten the relief you want. And then to the next step of, but hey, we have options. We have therapies we can talk about. And again, I love the other part that you mentioned, is we know that IBS is multifactorial pathophys, but it's also really complicated with symptoms, right? One patient is coming in because of pain, one is coming in because of the bowels, one is coming in because of that incomplete evacuation. And I love that goal setting of shared decision making of, for each patient, what is driving them in for their care.
Yeah.
So next question, like, curious, as a healthcare provider, when we start to talk about any therapy with our patient, prescription, pill, injection, sub-Q, any disease state, right? There's always this misconception, this fear of risk of being on a therapy. How do you talk to these IBS patients about that? Like, it's a pill in this situation, but it's still like all the, well, I heard about this, I read about this, am I going to be dependent on this? Like, do I need to take it my whole life? I mean, what does that conversation look like?
So I got some pearls that I can share about that. So a lot of times when they pick a medicine that they want to try, I will tell them first, okay, you really need to take it at this time, or on an empty stomach, or with food. Really hone in on taking it consistently, because we want to make sure that we can see trends. We also want to see if something works, right? But with these patients, you have to give them, alarm signs to think about. So some of these patients, you want to avoid certain medications when they've had a history of like a bowel obstruction. So make sure that you understand that and give them signs or alarm symptoms that they need to call or stop the medication. So, but I think the big thing is with this type of patient population, they're so afraid of getting addicted to these medications, right? Oh, this is something that I'm going to rely on for the rest of my life. But I take it a step back and I say, okay, because this is a real disorder, you have to think of it just like you would with any other disease or disorder. So if I'll give a comparison, if you had a blood pressure problem, right, you'd want to take the medication to help that blood pressure problem. But if you stopped taking it, your blood pressure's got to shoot right back up, right? Same thing with the medications. You want to take the medications, and if you stop it and it has been working, it's not going to work anymore. So it's the same kind of situation, and we really have to just approach it that way.
I really love that analogy, right? Because I think when we think about this, chronic, right? It is a chronic disease. Yet it's really interesting, Christine. I know I see this, you see this. I know there's statistics about this. And maybe we all need to remember that education piece of chronicity, because the data out there does show that the patients on a prescription for IBS-C, for CIC, up to 41% of them discontinue this therapy, right? And we've seen
You'd
this.
think it would be higher, right?
Yeah. And maybe it is higher. This is the one I know about. And I think it's really complicated, right? I think the first part, if you don't mind, that we can tackle is like there are some possible side effects with these therapies, right? And so obviously diarrhea. Talk to me a little bit about that. Like, how do you set that expectation? What do you tell the patient? We know, thankfully, with most of these therapies, it's mild to moderate, it's transient. So like, what's your words to these patients to remind them, like, don't stop it if that happens up front?
Right. So you can be very constipated, start a medication, and after 1 or 2 days, you're like, oh my gosh, I have so much diarrhea. So I try to pre-counsel my patients on this. You know, it's normal if you get a little bit of diarrhea the first day or two. It should normalize over time, and it shouldn't be a problem. If at that point you're struggling and you've been hydrating, you've been watching out for any blood, or, you know, it's happening. If it's happening multiple times a day, I would really want you to give me a call. But generally, after a couple days, it should resolve. And there's something called fecal overflow. So if you haven't had a bowel movement for a number of days, and then you finally start the medication and opens up that gate, it's going to come out pretty fast. So that's the rationale for why you're going to initially have those loose stools.
I think that's great. And I think, again, it's all about setting expectations for our patients. I'm going to ask you in relation to expectations for patients, right? We know, as I mentioned, there's multiple pathophys, particularly dual pathophysiology. When we think of, you know, fluid secretion, motility, kind of leading to the constipation aspect, but then obviously the visceral hypersensitivity leading to the pain aspect. And so regardless of what therapy we decide on for our patient, we know there's different timeline expectations for what they should anticipate and expect with improvement of their bowels, but then improvement of the pain and the bloating.
Yeah.
How do you kind of set that expectation, right? Knowing that we typically see improvement of the constipation first, pretty fast. The others can take a little bit of time. Can you walk me through that guidance?
Yeah. It's so important that we separate those, right? Because a lot of times patients will say, well, this should just take care of everything. And that's not necessarily true. So this is where we have to talk about, okay, look at the patterns in your bowel trends, and then also look at the patterns in your pain improving. Sometimes the pain takes longer to get better, and sometimes there's only a certain level of improvement that you're going to expect in your patient for multiple reasons, maybe other medical comorbidities, et cetera, or surgical interventions. But with certain medications, you might want to utilize them because they might also help with pain. Like certain laxatives might also help with pain. There's also other laxatives that might help with bloating, but some of them can even take up to 9 weeks to get an improvement. So it's really just counseling the patient on whatever medication that they choose, that they understand that it's going to take time, and giving them that information so they don't say, you know what, I'm done. It's been a couple weeks and nothing's getting better.
Yep. So important, right? And I just want to echo that. I think as we try and talk about getting compliance improving in these patients, you hit the nail again, like understanding the chronicity of the disease, the chronicity of meds, but also understanding that typically the bowels improve first. And you said it can be 8, 9, 10 weeks. And we really want to educate our patients on that, whether you're fortunate enough to get samples or whether you remind patients that at the end of your first month, if your bowels are better, but your pain or bloating isn't, we can still see that improve with more time. What about those patients, Kristina? Like they do great, right? And we see this very often. And I think you can go back to your blood pressure analogy. Like they're taking their meds, they're doing great, they're wonderful, but then they're like, "Oh, I'm so good. I don't need this anymore because you cured me, and I'm gonna go and I'm gonna stop my X medication tomorrow because my IBS is cured." Like, what does that conversation look like when they come back and see you and their symptoms are starting to kind of slowly creep back.
Yeah. So this is where I remind them about the disease itself or the
Yeah.
diagnosis
Yeah.
itself and just say, hey, listen, if you, want to have the same type of outcome, the best bet is to continue on the medication. And if that stops working while you're on the medication, then we should really have a conversation about maybe swapping to another medication or, something else. But it's important that you continue the medication and you help your bowels in the ways that they need to be helped.
Yeah.
And, one of the other things I've noticed too, Kim, is a lot of times patients, they don't necessarily see the benefits over time. And they look at just the end goal, right? So what I try to tell patients is if you can put a bowel diary and a pain diary and then look at those trends over time, you'll notice the improvements. And it might
Yeah.
not be huge and dramatic where initially you would notice, right? But those small benefits over time increase. And then at the end, you'll notice, okay, maybe I'm now 70% better. And that's a
Yeah.
huge win.
Yeah. And I think we can help with that, Kristina, too, right? I think like we talked about APPs, great histories, we document really well, right? So I think for those patients, when we have that kind of baseline, right? They're coming in and they're having one complete spontaneous bowel movement a week and they come back and they're like, well, not that much better. It's like, well, you just told me you're having 3 or 4 complete
Right.
spontaneous bowel movements a week. Like, let's look back and think about where we started and where we've come. So one other question I have for you, what is kind of your follow-up period when you see these patients back, right? You see them, you've given them that diagnosis, and now you're like, great, I not only give you a diagnosis, I want to help you. We're going to start you on this therapy. What does that follow-up look like? And why do you decide on that sort of time interval?
Yeah, I totally realize like not everybody can have frequent follow-ups, right? But this is where the patient portal might be very helpful. If you can, ideally after starting a treatment, you might want to see them back in the office maybe 4 to 6 weeks after starting. Sometimes I also often ask the patient to send me a message after 2 to 3 weeks on what they've noticed or if there's any issues. They should let us know ahead of time if there's anything, that warrants a sooner evaluation. But yeah, I think it's just
Of like factoring in that patient sitting in front of you, right? So I think we could say, ideally 2 to 3 months, we want to see them back, but
Yeah.
think about that person sitting in front of you. Is it a follow-up? Is it telehealth? Is it a portal message? Some
right.
people like visits, but some sort of follow-up to make sure they're doing better. And again, bearing in mind the expectations of certain symptoms might be better.
Mhm.
Maybe not all are, but I think it's a way that we as providers can increase their adherence to their therapy by checking in on them and making sure they're taking it and
Yeah.
they are getting some improvement of symptoms.
Yeah. I mean, I think one of the big things is you don't want to wait a year. You don't want to wait 6 months for these people to come back, especially since we know that 41% or higher
Yeah.
tend to stop these medications. And then, they start to get discouraged again because, no one's going to be able to help me with this. So it's just important that we,
Well,
as APPs, we have these opportunities to be more involved with our patients. And one thing I like to tell my patients to make sure that they follow up with me is I can give you recommendations, right? But it's like driving a boat. You can drive the boat. I can give you to turn left or right, but it's really up to you to turn the wheel and to do those things. And
yeah.
if you're able to do those things, I can help guide you during the process. So that's why the importance of follow-up is it really should be, maintained.
Yeah, I mean, I think the whole point, right, is we can help increase their adherence, right?
Yep.
Their education. And by more education, we get more adherence. And with more adherence, we hopefully get greater patient satisfaction,
Yep.
improvement of quality of life.
Yeah.
I do want to call out for those listeners that there are some resource that we as APPs and all healthcare providers can utilize to support these discussions as we're starting to talk to patients about treatment decisions and as we're starting to talk to them about why it matters to take your medication every day and just really about setting the expectation for what to expect with improvement of symptoms. We're going to share in the link one specific guide that you can utilize, but there are multiple guides. So just remember, we're never alone in this. We have colleagues we can talk to, but we all want to help to educate and improve our patient outcomes with IBS. And particularly when it comes to initiating therapy, we want to do everything we can to set those expectations, whether it's about side effects, tolerability, realistic expectations for timeline of therapeutic benefit. and again, follow up with their providers. Kristina, any tips for our listeners to kind of end the session today?
Yeah, I think the big thing is to empower your patient, right? Empower them to be the main player in their treatment plan. They're the ones who are doing this. They're the ones who need to get better. But if we really listen to them and know that, and they know that we're in their corner, I do think that their outcome will improve over time.
That's great, Kristina. I think especially for APPs, right? We really try and do that shared decision making, that education, that empowering the patient. So a great reminder to all of our listeners. Kristina, thank you. I mean, it's always fun chatting. I know this is something you're really passionate about.
Yeah.
To all of our listeners, thank you for listening. Just a reminder, there are other podcasts and learning materials on the GAP website, as well as on the GAP ACE app. So we hope to see you guys all again soon.
Thanks, everyone.